Hello, everyone, and welcome to week 2, NUR 300, Nursing in the Contemporary U.S. Healthcare System. I am your professor, Dr. Marion Johnson, and welcome. Welcome back. I hope everybody had a great time in week 1. I hope everybody learned something in week 1. So let's get started. So this week we're going to be discussing issues affecting healthcare, and we're going to start off with paying for healthcare in America and the rising costs and challenges. So, in the past several decades, the costs of healthcare have continued to increase, with economic issues taking a central role in healthcare decision making. Hospital managers, known for the most patients the hospital will receive a predetermined payment regardless of length of stay and specific treatments. Physicians and nurse practitioners recognize that the prescribed course of treatment for their patients may be analyzed by a peer review committee. The costs their patients incur may be compared with those of other providers or against cost benchmarks. Businesses require employees to cover larger amounts of their healthcare insurance premiums and or pay larger deductibles and co-payments. Health insurance companies manage care, sometimes placing limits on medical care coverage on providers in the network or on the site of care delivery. The Patient Protection and Affordable Care Act, PPACA of 2010, added a new dimension to healthcare financing with various insurance options for universal coverage of American citizens and alternative modules of reimbursement to promote quality and cost-effective healthcare. So, healthcare financing revolution of the 1980s. The rising cost of healthcare over the last 50 years is a dangerous trend that poses a significant threat to the U.S. economy. In 1965, annual healthcare expenditures in the United States were $202 per person. In 2006, the national health expenditures had risen to $10,348 per person. Total healthcare spending increased from $1.3 trillion in 2000 to $3.3 trillion in 2016. National health expenditures as a percentage of the gross domestic product, the GDP, was 17.9% in 2016 and is projected to be 19.9% by 2025. This means that for every dollar a person spends buying products or services in the United States, almost 18 cents goes to pay for health care. In contrast, healthcare spending in 2017 in neighboring Canada was expected to reach an all-time high of $6,604 per person in 2017, with a healthcare GDP of 11.5%. To control rapidly rising health care costs, Medicare moved from a retrospective fee-for-service payment system to a prospective payment system, PPS, based on diagnosis-related groups, DRGs, in 1983. This shift was critical for the hospitals because Medicare is the largest paying single payer of hospital charges. Under DRGs, each Medicare patient is assigned to a diagnostic grouping on the basis of his or her primary diagnoses at hospital admission. Medicare limits total payment to the hospital to the amount pre-established for that DRG. Unlike the previous approach, in which hospitals billed Medicare for any and all services provided to patients, and Medicare reimbursed these charges with a generous payment schedule. Since 1983, if hospitals' costs exceed the DRG payment for a patient's treatment, the hospital incurs a loss, but its costs are less than the DRG amount, the hospital makes a profit. Thus, hospital faces a strong financial incentive to reduce the patient's length of stay and minimize procedures and tests performed. Although DRGs originally applied only to hospital payments for Medicare patients, similar reimbursement arrangements were initiated by private insurance companies. Implementation of DRG system created a new role for nurses as utilization review experts to review medical records and determine the most appropriate DRGs for patients. The development of managed care. With the shift to prospective payment under Medicare, private insurance companies followed Medicare's lead and developed managed care. Managed care organizations, MCOs, encompass several different approaches, such as health maintenance organizations, HMOs, preferred provider organizations, PPOs, and point of service, POS plans. The primary commonality among all of these health plans is that they use some method to review and approve or deny the use of healthcare services. In this review process, the patient's medical options are reviewed by a nurse or physician employed by the health insurance company, and a judgment is made as to the necessity of the service being considered. Coverage may be denied for unnecessary, excessive, or experimental procedures, in strong contrast to the previous, if it might help do it approach. The goal for managed care is to minimize payment of charges for inappropriate or excessive healthcare services. Access to healthcare, the problem of the uninsured and underinsured. As healthcare costs continue to rise dramatically in the United States, one major issue that must be addressed is access to healthcare for the uninsured and the underinsured. Prior to the passage of the PPACA in 2010, lack of access to healthcare primarily reflected a lack of insurance coverage. So access was an issue of financial access. The uninsured and underinsured included the working poor employed by small businesses without insurance coverage, part-time workers, unemployed persons, and the homeless. The poor are more likely to lack usual source of care, less likely to use preventative services, and more likely to be hospitalized for avoidable conditions than those who are not poor. The uninsured and underinsured populations generate uncompensated or indigent care costs and bad debt for healthcare providers. Unpaid costs must be covered by those who do pay so the hospital can continue operating, a process known as cost shifting. Providers increase their charges against households and public and private insurers who pay for care to make a contribution for the care of the uninsured population. This practice raises insurance premiums, making it more difficult for many households and businesses to afford coverage. The problem of uncompensated care and cost shifting was a major factor leading to healthcare reform and the passage of PPACA. In 2013, the percentage of the population without healthcare insurance for the entire calendar year was 13.4%, or 42 million people. In 2016, the percentage of people without health insurance was down 8.8%, as a direct result of the availability of more affordable health insurance options through the PPACA. Despite these advances in providing health insurance through the PPACA, there are still about 28 million people in the United States without health insurance. People most likely to be uninsured are low-income adults and people of color. The major barrier to obtaining and maintaining health insurance is the cost of coverage. Lack of health insurance is perhaps the greatest barrier to accessing healthcare services and has a tremendous negative effect on an individual's overall health status. Private insurance. Private insurance accounts for the largest percentage of coverage for healthcare, with the cost of providing health insurance to employees passed on by the employer to the consumer in the pricing of goods and services. This means that everyone pays a part of the country's healthcare costs in every purchase made. Individuals still must pay a portion of their healthcare costs directly from their own pockets through payments for insurance premiums, deductibles, and co-payments. With managed care products such as HMOs, PPOs, and POS arrangements, the premium the consumer pays for coverage has continued to rise. In response to these concerns, some companies now offer their employees high-deductible health plans, HDHPs, health reimbursement accounts, HRAs, health saving accounts, HSAs, or a combination of these. These plans are more flexible. These plans offer more flexibility and consumer discretion over their healthcare dollars and provide a tax-free way to save for future healthcare needs. Public insurance, Medicare, and Medicaid. Government is the biggest influence in the healthcare insurance market, generating half of hospital revenues and more than 1/4 of physician incomes. The largest government health insurance program is Medicare. Medicare is an entitlement program based on age or disability criteria, rather than one on need. Medicare Part A covers inpatient hospital services, skilled nursing facilities, and home health benefits. Medicare does not cover long-term care. Hospital coverage has deductible and co-insurance requirements and some coverage limitations. Medicare Part B covers physician and outpatient services. In January 2006, Medicare added access to a prescription medication benefit, a noted and costly change from previous benefits. Medicaid is a joint federal-state program to provide health insurance coverage for impoverished families, particularly those with children. Medicaid, along with the Children's Health Insurance Program, CHIP, offers health care coverage to more than 62 million Americans. Those eligible for health care services include pregnant women, children and parents, persons with disabilities, and seniors who meet certain income criteria. Each state administers its own Medicaid program within minimal federal income guidelines, so some variances can occur from state to state. PPACA expanded the minimum income levels for Medicaid eligibility for those less than 65 years of age, effective January 1st, 2014. However, according to the 2012 Supreme Court ruling on PPACA, states have the right to opt out of offering the expanded Medicaid coverage. Medicaid is a primary payer of long-term care nationwide. Medicaid represents the fastest growing component in most state budgets.